Hello, welcome to today's webinar, Palliative Caring, Improving Care Through Early Integration of Key Palliative Principles. My name is Sarah Tirani and I'm the Program Coordinator at Triage Cancer. I'll be moderating today's webinar. Before we dive into today's topic, I just need to go over some housekeeping. All callers will be muted during the duration of the webinar. If you have any questions or technical problems, please type them in the chat box to the side of your screen. This webinar is being recorded and will be available for viewing at the end of the week on our website, triagecancer.org. At the end of the webinar, you'll be redirected to a survey. Please take a few moments to fill it out and let us know what you think of today's webinar. Oh, excuse me. There we go. Sorry, there's a little drag there. All right, first of all, we are very grateful to the support of Novartis Pharmaceuticals as a sponsor of the 2018 Triage Cancer webinar series. And as part of the accreditation process to give you CEUs, we have to disclose that the planners and presenters of this program have not disclosed any pertinent financial relationships or conflicts of interest. This education program does not have any commercial or non-commercial support other than the support listed from the sponsors and partners. This presentation is intended to provide general information on the topics presented. It is provided with the understanding that the author is not engaged in rendering any legal, medical, or professional services. Although this content was reviewed by professionals, it's not to be used as a substitute for professional services. The planners and presenters of this program have not disclosed any pertinent financial relationships or conflicts of interest. While this education program has received commercial support from the previously listed sponsors, the content has no relation to the commercial interests of the organization's product or services. Oh, excuse me, we're going backwards. There we go. And we're very excited to announce that Triage Cancer is now an accredited provider of continuing nursing education by the American Nurses Credentialing Centers Commission on Accreditation. Therefore, nurses participating in the live webinar will be eligible for 1 contact hour of credit. And this is true of all the webinars going forward for the year. So we have approval for nurses thus far, and we are still awaiting approval for the social workers. Now, in order to receive your units, you must have registered online for today's session. People who are listening in on someone else's computer or phone will not be eligible for credit. You also must attend the entire webinar. No partial credit will be awarded. And anyone watching a recording of this webinar will also not be eligible for credit. It is only for live viewing. Within 1 week of the webinar, complete the evaluation and post-test. You must receive a passing grade on the post-test to be eligible for CEUs. You will receive an email following this webinar about 1 hour later that will contain the link of the evaluation and post-test. Please note that the evaluation asks for your name and email address, and you must include this so that we can certify you completed the evaluation. The email is the address that we will mail your certificates, and we'll be sending those out within 4 to 6 weeks. And again, we are only offering CEUs to nurses at this point. If you have any questions or experience any problems, please email us at info@triagecancer.org. Now, for those of you who aren't aware, Triage Cancer is a national nonprofit organization that provides cancer survivorship education on topics that arise from the point of diagnosis throughout life. And we do this in education in a couple of different ways. First, we host a speakers bureau of experts in all types of cancer survivorship issues available to organizations putting on an educational event. You can read our speaker bios and request a speaker on our website. We not only participate in events all over the country, but we host our own educational events for patients, survivors, caregivers, advocates, and healthcare professionals. We host a series of conferences on a variety of cancer survivorship topics. This year's events will be held, well, it was held in Ypsilanti in May, and it will be held in Reno and Lewiston. Travel assistance is available for patients and survivors to attend the Reno and Lewiston, Maine conferences. So if you have a patient, please direct them to our website to apply for that. As you know, we host a monthly webinar series. The next one will be on July 12th, Hot Topics in the Law. That will be hosted by Joanna Morales. In partnership with Cancer and Careers, we offer a free one-day training for healthcare professionals called Navigating Cancer, Work and Finance. For more information about this, you can visit our website. We also offer a rather new program called the Insurance and Finance Intensive. This is a comprehensive certificate program for oncology healthcare professionals and advocates on health and disability insurance and finances. We're hosting the next intensive on 8/23 in New Orleans. Registration is open on our website. In addition to our events, we offer a number of online and educational materials and resources. Our quick guides are designed to be a snapshot of a particular topic. They cover areas such as health insurance, employment, clinical trials, financial topics, estate planning, and legal assistance. You may order hard copies of the materials on our website or at triagecancer.org/material request. We also have state-specific resources on our site, including topics that you will hear about today. And because where you live can impact what protections you have access to, we have charts of state laws on employment, disability, and health insurance related issues. We also provide educational animated videos on cancer survivorship topics. We have this one on health insurance basics with key information that you need to know about your health insurance plan, especially to minimize out-of-pocket costs. These videos are available in English with Spanish subtitles. And we also have cancerfinances.org, which is a site that we host in partnership with the SAM Fund that provides practical information on topics that can impact your finances. We also provide contact information for financial assistance resources. We just released a new module on education, which covers education rights in school, accessing accommodations, and dealing with student loans. Our educational blog not only provides great information about cancer survivorship topics, but because things are constantly changing in the cancer community, this is how we share any late-breaking news. We also have a monthly newsletter, which is where we announce all our upcoming events. So any of the intensives or in-service programming we have will be announced there. And that brings us to our speaker today. I am delighted to introduce you to today's speaker, Shirley Otis-Green. Shirley is the Clinical Director for the Coalition for Compassionate Care of California and the founder of Collaborative Caring. Shirley, welcome.
Thank you so very much. It's a pleasure to join you today. I'm delighted again to have you on a series on survivorship, be willing to play with the phrase palliative care. We know that many folks think of palliative care as being synonymous with end-of-life care, and that survivorship and end-of-life care are seen as two opposite ends of a continuum. But what I'd like to have us consider is the possibility of integrating the palliative care principles that we know are effective earlier upstream, and so that these are indeed relevant for those of you who are really focused on survivorship and survivorship issues. And I'm trying to advance my slide, and Sarah, I'm asking if you have any suggestions. I've pressed my arrow key. Otherwise, I'm going to ask you if you can advance.
Hold on, Shirley, let me figure this out. You should have the mouse control. Can you just kind of wiggle your mouse around and see if that does it?
Can you see me? I'm wiggling my mouse. I'm touching your arrow. It seems to be indifferent.
Huh.
I know.
Okay.
But thank you.
All right.
And so my assumption going into this is that we actually all in healthcare have an ethical responsibility. Our goal is to ensure excellence in care. And although it's most important at end of life, the only reason for that is because we don't get a do-over. At that point, you know, it really is that one moment, that little window of opportunity. So the urgency is absolutely there at end of life, but arguably it's not limited to that. So our goal is to create innovative strategies so that we can deliver care in the most efficient and effective way possible. We want to support our colleagues as they provide quality care. And I think all of us need to act as an advocate or a change agent so that we can improve quality of care for those who are the most vulnerable. Again, I'm a social worker, and so social justice is really important to me. And I think, again, for all of us in healthcare, we have a special need to pay attention to those who are the most vulnerable. And of course, that includes the very young, the very old, those who might be marginalized, and those who are closest to death. And I'm going to ask Sarah if you can advance my slide again. So when I think about this, I've come up with this term palliative caring, and taking care and really putting that word in terms of a more action associated word. My objective is to recognize the importance of cultivating a collaborative interprofessional approach so that we can address the multidimensional sources of suffering, and to explore strategies of how we can take palliative care principles and move those upstream so that we can improve quality of life for both patients and their families. Next, please. Then,
Shirley, could you try it one more time? I'm sorry,
um,
I didn't mean to
yep,
interrupt your flow.
no, that's fine. I'm pressing the buttons and I'm moving my mouse. And I'm still seeing
Still not
indifference
going.
from,
Okay, we'll continue on with me advancing.
thank you. I appreciate your having someone at your back is a key piece. So healthcare, I think at this point in the world is at a crossroads. Here in the US, we know that there have been efforts for healthcare reform that have been more recently being dismantled. And as to where, if we were to be betting folks and say 5 years from now, where is this going to end up? You know, the odds are not good that we'd be able to predict what that's going to look like. I suspect that we're going to have it look different than it currently does. And there's lots of reasons for that. But I think that we want to be thoughtful about the fact that there are choices that are going to be and continue to be being made. And we, again, are hopeful that we can influence those choices so that we can be taking the high road in this. Next slide, please. Wise people have said things like, life is pleasant, death is peaceful, but it's the transition that becomes troublesome. And that's what we're really about. When people are healthy and well, we're not seeing them in healthcare. When they're actually dying, we're not seeing them in healthcare. It's the when they're actually dead, excuse me, it's that in between that's troublesome. And so our work is to try and make that in between go as well as it possibly can. Next, please. And unfortunately, our current healthcare system has not been able to deliver the highest possible care to all folks who need it, and there's lots of evidence for that. Our healthcare system, unfortunately, is broken. So if you can advance each of these, you'll see that there's a series of Institute of Medicine reports, and each of those, unfortunately, is packed with evidence of opportunities for us to do better, outlining places where we've not been able to provide the kind of quality care that, again, we would like for our own patients and our own families if that were the situation. Next, please. There are growing deficits in the delivery of care. For example, we know, and those reports emphasize, that we have an unsustainable system, both in terms of cost, but also in terms of workforce shortages. We know that at this point, I think the average age of nurses is around 56 or 57 years of age, and we don't have enough people in the pipeline to replace. We have a lot of folks and a lot of literature that supports that people in healthcare have high dissatisfaction, high rates of burnout, compassion fatigue, moral distress. There's, from the patient point of view, there's inequitable access to quality care, which is really troublesome. Yet in today's world, we know that if people come into an emergency room from the same accident, from the same, with the same injuries, that there's a probability that the person with lighter skin will get better care than the person with darker skin. It's really a terrible indictment to our system. There are training deficits. We know lots of folks go into their professional practice without having the kind of communication skills that would be necessary to deliver care optimally. We know that there's a growing number of people who are getting older, and so the need is increasing while we have less folks to provide for that need, and that our traditional medical models lead to what we might call default treatment decisions. And we too often in the medical model, we treat the liver in 206, not the person in 206. And so we have, again, unfortunately, increased costs and less satisfaction, both for the public and for providers. Next, please. So we need, because we know again how to do better, we need to have the courage to actually make that happen. For too long, healthcare has been decided by others than healthcare providers and by the patients that we serve. And so arguably, this is a call to action. This is an opportunity for us to think about how we might be change agents, how we might be able to influence care, again, to make an improvement. Next, please. Gandhi has been quoted as saying, "You must be the change you wish to see in the world." And that's really what we're going to suggest here today, that each of us on this call really think about opportunities that we might have to improve the care that we deliver. And next, the slide previous to this one, please. There we go. The seamless integration of these palliative care principles, I think, is part of the answer. We've just discussed this series of problems, but what we know is that palliative care, or the principles related to palliative care, are associated with improved quality of life, improved functioning, that palliative care contextualizes care. Again, it's not just the organ or the injury area that is of concern, it's the whole person and their family. It addresses those multidimensional aspects of suffering using a collaborative team approach, looking really at the physical, social, spiritual, psychological, and existential concerns that real people dealing with real illness face. Next, please. What palliative care does is prioritizes what matters most. And the only way we can know what matters most to an individual is by listening, by doing an assessment, by ascertaining what matters most to this particular patient at this particular time, and what is interfering with their quality of life right now. Being able to prioritize that for the rest of the healthcare team is a real key piece of what makes palliative care so powerful. The next slide, thank you. Palliative caring, again, taking this concept and saying what we want to do is provide a real system that is about the care for an individual, and making sure that the care that a patient receives is associated with the care that they actually want, that we prioritize what matters most to those individual people. So if we go to the next, please. We know that care needs to be individualized and culturally congruent. We know that each individual that we see may have a different worldview, and that some folks may prioritize family welfare over the individual, or that family may be a very extended kinship network, or that roles may differ from what our kind of traditional Western model expectations are. And that leads us to this concept of dynamic sizing. We know that when we go to literally to a restaurant or shopping, you know, that we're presented with lots of choice. Our consumer world recognizes the importance of individualized care or individualized options in a way that unfortunately the healthcare system has been a little bit slow to do. So we need to recognize it's not one size that fits all. Again, default treatment of a diseased organ versus attention to the whole person has been problematic in healthcare. And what palliative care does is help give us tools and skills and strategies so that we can individualize care. Next, please. So with palliative care, we can think of these key concepts, and you could take any letter of the alphabet, but I pull up C because, as you can tell from where I work and the things that I do, that C is one of my favorites. And so I've just listed here a series of C's that are associated with palliative care. It's collaborative. It's about coordinating the care. It emphasizes communication. It requires compassion, competence, continuity of care across settings, courageous questioning, conviction to principles, and another one, please, the commitment to excellence. What these do is allow us to contextualize care so that we can offer care that is, again, associated with what this individual needs at any given point in time. We could look at each of these in regard to, here we're going to think about some of the lessons I've learned as a palliative social worker, that it provides us this multidimensional, culturally sensitive systems focus that can help us to address the needs of specifically those that are underserved, where again, if we do this appropriately, we become the conscience of our communities and of our organizations, and it can assist us with the patients who are dealing with transition and loss. And arguably from the moment that a person is diagnosed with a serious illness such as cancer, those are the two key constructs that, again, I think become of focus. The person leaves their, quote, healthy state and now, finds themselves a cancer patient. That's a transition that's associated, again, with many losses, even if they are fortunate and are able to go back into a healthy extended life, that in survivorship, they still have had to face the loss of their previously seen healthy self. Having a diagnosis of something like cancer invites a person to reflect upon the possibility of their own mortality in a way that, instead of it being a theoretical, hypothetical, suddenly becomes a much more real, visceral consideration. Next, please. And so that provides us the opportunity to think about the essence of what we all do, is looking at the relief of suffering and the minimization of regret. These are powerful works from the fabric artist Deidre Scherer, and she has created these beautiful portraits of people often that are in hospice. But again, regardless of the person's level of health, there is association of suffering related to serious illness. And certainly for both the patients and their loved ones, the possibility of regret. Too often we hear people say, if I'd have only known, I would have done this differently. So being able to think about how can we integrate these principles? How can we help folks to better understand this different way of thinking about care? And that led us, next slide please, to the work that I do with the Coalition for Compassionate Care of California to apply for a PCORI award. Now, PCORI is a wonderful organization. It's a funding organization nationally that offers support for patient-centered outcomes research. And their goal is to think about doing research differently than it's been done in the past, to be more person-centered, to be really looking at what are the outcomes that matter most to real people in the real world. So it was a perfect fit for us for this goal. And we were fortunate to receive a $250,000 award for 2 years, just beginning in June. So this is all brand new. And our award is called Transforming Care by Engaging Patients as Palliative Care Ambassadors. And what we're going to do is bring together patients who are, we call them e-patients, but patients who are actively involved in social media, and assist them in coordinating with an advocacy organization, for example, the American Cancer Society, or perhaps a smaller local organization that works with folks and help these patients be the liaison to the integration of palliative care principles. And our hope is then that we can create communication campaigns so we can increase consumer awareness, which again, we hope will drive consumer demand for palliative care. So for example, what we want to do in this is to think about, well, what are those palliative care principles that might be important to real people? We know that there have been studies that have been done that ask, if you grab 10 people off the street or, shopping in Walmart and say, what is palliative care? Most of those 10 people are going to be a little bit unsure. They might have if they know the term at all, they might associate it with hospice and think it is associated with end-of-life care, or they may literally say they're unfamiliar with the term completely. But there's either myths or misconceptions or misunderstandings about palliative care that make it hard for someone to go into a hospital or to a clinic setting and request something that they don't really know. So we know that when we take the elements of palliative care and talk to people, that we get a very different response. We say, well, are you interested in care that focuses on improving quality of life? People are very interested, of course, in that. Or care that's associated with improved functioning. Well, yes, I want to sign up my mom to get that. Um, Care that provides exquisite attention to the multidimensional sources of suffering. Again, that physical, psychological, social, spiritual, existential. People, again, are very eager for that. Care that has a collaborative team approach. People recognize that one person can't possibly do all things. So being able to see a team that works together is something people are interested in. If you ask people if they're interested in having care that's contextualized, again, that prioritizes what they care about, that helps them to develop shared goals of care with their team members and has a more relational focus versus a transactional focus. People, again, are very eager to have those things occur. So our hope is that things like a future walk for awareness for a cancer organization, that has 10,000, folks marching together on a given day to raise awareness for breast cancer, for example. When people cross the finish line, that not only in their goodie bags will they get information about the disease-specific things, but they'll also get information about these principles that we've just been talking about, and that they'll be able to feel more enabled and empowered to talk to their care providers about this level of care. For example, we might picture a Komen breast cancer awareness walk that would include a tent or a booth that has advanced care planning opportunities with perhaps a notary that's there so that people can actualize the benefits of advanced care planning by completing an advance directive right at the same time that they're having this activity. We think being able to integrate these kinds of things will go a long way toward increasing consumer demand. Next, please. We take comfort from a wonderful woman who's done a lot of systems work and done work in family systems in particular. Her name is Virginia Satir, and as a budding social worker back 1,000 years ago, I was excited to learn about a principle that she had, and that figure is meant to represent a child's mobile. You might see something like this hanging above a baby's crib. And what we know about mobiles is that they have homeostasis. They seek to be balanced, and they will right themselves and stay stable until something happens. But when something happens, if you take a paper clip and clip it onto one of those elements, it changes not just that element, but all of those things that are associated on the mobile. So if you imagine a paper clip on the little purple square, you would again find that they lose homeostasis, and all of the other elements of the mobile bang around a bit until they adjust to this new weighted world. And the diagnosis of cancer is exactly like that. It changes everything in that person's milieu. So the patient with cancer is different now in her role as a mom or as a daughter or as a sister, as a wife. There can be sexual and financial and spiritual implications. There can be concerns about work and managing her roles. There can be so many things that are knocked around, in the process of dealing with their illness. And having a multidimensional approach to address those things, not just of the patient, but of the family and the community, to give them assistance in regard to managing these conflicts and rewriting themselves, is an important aspect of what palliative care does. It also gives me comfort in that it reminds us that if we make us even a small change for just one patient or just for one unit or for one hospital or medical system, those changes affect the rest of the players in that mobile as well. And so just by changing the way one social worker or one nurse or one physician communicates with their patients, we make a difference that has a ripple effect out broader. And that, again, can help us to be motivated to continue this work. Next slide, please. And speaking of motivation, I think it's important for us to be mindful of what our purpose is, what our true North Star is in this good work. Those of us who go into healthcare want to do what's best for the people that we see, but sometimes the daily grind can take a toll for us, and we can really lose track of that importance. And sometimes, again, the bureaucracy can make us feel impotent. But what palliative care reminds us is that we are making a difference. This work is associated with better outcomes. And so it can help us, again, to maintain our focus and our purpose and our motivation. Next, please. Those of you who are listening to this webinar, I invite you to take a moment, even now in real time, and think about your own personal motivation for this work. And for many of us, doing this work allows us the absolute amazing privilege of sitting at the bedside of people who are facing their own mortality. And there are lessons we can learn from that. We have the opportunity to see dying done by experts and to be able to take the lessons learned from that experience and apply that to our own personal life. If we're reflective, and I hope that all of us are, if we are reflective practitioners, we have the opportunity to think about what kind of care would we hope that our loved ones would receive, or that we ourselves would receive if we were to find ourselves in this situation. If I am honest with myself and reflective, I know that there are gaps within my own institution, and that can provide the professional motivation for me to, again, want to improve the care delivery. I know that we do, when I was working in a cancer hospital, and I did that for some 22 years, we did many things well. I could be very proud of the work that we did in general. But if I were honest, I would also have to recognize that there were some serious gaps. The care we provided with our A team might be a little bit different than the care that we could expect from our folks that we're covering on weekends or holidays, or perhaps at evenings, or in the middle of the night. And so being able to be thoughtful about where are those opportunities for improvement. It's also important for us, though, to be focused on empowering the things that work. And so being able to identify those areas of success. How can we amplify those? What can we do that can allow us to actually make a difference by spreading the things that are working well? There might be a particular physician, or a particular unit, or a particular care area that just it's smooth and seamless, and the patients just do so well that are there. Being able to identify what works and how can we expand that to those other areas is a really tremendous opportunity for us. Next, please. Being able to be on the side of the angels helps us to feel much better about the work that we do. We know that we feel better when we do better. I remember, again, when I was doing the work at the hospital, my office overlooked the parking lot. I was fortunate to have a window at all, so I was very thankful. But nonetheless, it was a lovely view of the parking lot, and I could watch the change of shift. And when the nurses came out from ICU and glumped together around a particular car with their arms flailing, that would be my sign that things had probably not gone well that day at the unit. And I'd see these people gesturing, and I couldn't hear anything, but I could see these wild gestures and people stomping about for a long period of time before getting in their cars to drive home. And I would know that there was great distress from these professionals who had committed so much of their time to trying to provide good care. And that brings me to what's often called the triple aim of healthcare, which is concern about population health and improving patient satisfaction and lowering cost, but now can be called the quadruple aim, where we recognize that we need to attend to provider satisfaction as well. And in fact, we can't get the elements of the triple aim unless we do attend to the care of the providers themselves. So this is what is wonderful about palliative care and these principles that we've been talking about is if we can improve the delivery of care, we not only can achieve improved population health and definitely increase patient and family satisfaction. It's been associated with lowered costs, which is wonderful, but it is also associated with improved provider satisfaction. We feel better when we do better. We feel better when we know that the care that we've provided is associated with the absolute highest standards. We know those of us who've done this work for a long period of time have often, if we're again reflective, we'll be able to identify times, hopefully rare, but nonetheless, they will have occurred where we felt that the care we provided was suboptimal or not aligned with that particular patient's goals and wishes. We might have been involved in a resuscitation effort for someone where we felt in our heart of hearts would not have wanted that choice if they had been able to have had an opportunity to have a conversation and been able to voice what their priorities really were. And it's those places of conflict for us that are so associated with moral distress. Next, please. We also know that palliative care is ideally not limited just to care that's received in a hospital setting. And hopefully on this webinar, we have providers or attendees who provide care outside of just the hospital setting. We know that care needs to be focused on where real people actually live, work, and play. So there's a big movement now for community-based palliative care, for us to be able to think about how we can adapt and adopt these principles that I've been talking about into the care that we provide in an outpatient setting. So those of you who might work in a clinic and be thinking, well, palliative care sounds great. Yeah, sign me up, but I don't have a social worker or a chaplain or the rest of a team that has expertise in this area. What can I do? How can we provide that kind of care? So being able to be thoughtful about how do we make choices and decisions in our workflow to carve out the integration of these principles is a really important question for us as we move forward. We know that at this point in time, too many folks will say that one of the areas of moral distress is that the system itself that they work in, whether it's a clinic setting or a hospital setting, is too often too rushed, too hurried, poorly staffed by people who lack certain key skills to provide the kind of care that they know they would want for themselves or for their own family. And it's that awareness, again, that's ultimately associated with this moral distress and with the burnout and people leaving the field, or with the newer generation observing those elements of frustration and not joining again in the pipeline. Next, please. So arguably, what this is all about, what even I mean by this term, palliative caring, is our audacious intention is to create a transformation in how care is actually delivered. Being able to think about how do we change the way we deliver care so that it changes back from being transactional to relational. Again, if we look historically, we know that early medical care, the way care was delivered before the 20th century, was very relational. We would have known the physician would have come to our home, we would have had care that was provided to us in a much more seamless way, but you could argue more ineffectual from a medical point of view. When we translated care into more of a scientific method, and we were able to have enormous breakthroughs in the 1940s and 50s that led to that led to radiation treatment, and in the 50s where we had antibiotics and incredible abilities to do anesthesia, which led us to surgeries that were completely impossible to imagine just a few decades previously. And then in the the 60s and 70s with great breakthroughs with chemotherapy, the way we provide care for oncology patients has been utterly changed. And again, wonderful advances scientifically that open the door to being able to increase the lifespan for people, so that we can have an entire field of survivorship. Wonderful things. But what I would urge us to think about is how can we reclaim and have a balanced perspective so that palliative care reminds us of the importance of being able to slow down the care delivery for any individual person and take a moment, take a deep breath to identify what matters most for this individual person. If that's the only takeaway that you have from this webinar this morning, I would think of this as a success. Our goal is to say what matters most to the individuals that we see and serve. If we can ask ourselves in our team meetings, what matters most? What are we striving to achieve? What is our true mission and vision and value? What's our purpose? What brings us together? We're going to go far toward being able to resize the way we deliver care and rewrite the ship here. If we can have the balance between, yes, all of these wonderful scientific breakthroughs and not have lost sight of the importance of being able to hold a person's hand and deliver news in a compassionate, careful manner, we will have gone far. Next, please. We know that what I've been talking about is a real change in how care is delivered. And so I love this slide. This cartoon says, the road to enlightenment is long and difficult, which is why I asked you to bring sandwiches and a change of clothing. Listening to someone pontificate for a period of time is not what makes change. Change is being able for us to think back and really reflect on the basic question of, would I be happy to know that my loved one was getting care in the place where I work? Would I feel confident that the care that they're going to receive, if they were seriously ill, is the kind of care that they deserve? To the degree that I answer that with a resounding yes, how wonderful, and congratulations to you for working in a place with such high quality. But to the degree that if you were honest, you would say, ugh, I wouldn't really want my loved one to be at this nursing home, to get their care at this clinic, to be cared for if they were seriously ill in this intensive care unit, at this hospital, at this time, or on these nights, or on these weekends, or during those holidays. If that's the case, then I urge you to roll up your sleeves and to use that motivation to take the long perspective and to take even those first steps toward making the care different. Next slide, please. For those of you who are overachievers and I want a homework assignment, I invite you to consider a couple of additional resources. There are a number of wonderful memoirs that have recently come out. One of my favorites is When Breath Becomes Air. It's a lovely testament to a wonderful young neurosurgeon who was just on an upward trajectory, everything looking really wonderful career-wise. And then he has a chronic cough, which leads to the diagnosis of stage 4 lung cancer. And this memoir is a wonderful reflection of his experience that he writes poignantly and honestly about his experience and the lessons that he learns from changing his perspective from being on one side of the stethoscope to the other. It's really beautifully written. And his wonderful wife, Lucy, finishes the novel, or excuse me, the memoir after his death. And there's again, a wonderful poignancy to this work, this testament to this man's wonderful life and his wise reflections. On the other end of the slide here, I have the book Flourish. And this is just a reminder that there is in psychology historically been a focus on what's wrong, what's maladaptive, what are the disorders of mental illness, this focus on what's broken in humans that has more recently broadened a perspective to positive psychology, the idea of understanding how are some people resilient? How are some people able to be facing a difficult circumstance and be thriving in that experience versus broken by it? And I put this in very intentionally when I was thinking about this presentation because I think it has applicability for us in two ways. One, I would hope that those of us who do this work are able to flourish in it. So I want us to have resilience in the work that we do and for us to be thoughtful and intentional about how we can create a venue that supports our colleagues and our team members and our collaborators in flourishing in their work as well. How can we create positive environments where we can actually enhance one another's well-being? So as practitioners, this is important for us. But conversely, I think it's also important for us to be knowledgeable about and skillful in at these aspects of positive psychology so that we can support the patients that we see. Again, this is a series about survivorship. We're going to see people who are faced with the difficulties of a serious cancer diagnosis, who go through serious and often arduous treatments. And some of those folks are going to live for decades beyond, but be wounded from them in such a way that they are depressed, discouraged, despondent, devastated from those experiences. And we then can question the morality of our work, the benefit of our work. Ideally, we not only help people live longer, but we help people live better. So being able to have in our toolkit, in our skill set, strategies to help build the resilience of the patients that we see, the ability to help empower patients to, again, see themselves as folks who are able to make decisions and have care that resonates for them, and again that they're able to be participants in their care delivery. Those are strategies and skills associated back with those palliative care principles we talked about that can help them to flourish with whatever time that they have left on this planet, whether it's days, weeks, months, years, decades, that they can do it as well as possible. That's ultimately our goal, that people have well-being for as long as possible in their circumstances. If we can help minimize, again, their suffering and help empower them to feel that they are really able to have care that is personalized and contextualized and prioritizes their means, they too can flourish. So it's a wonderful reminder that there's, again, a ton of work out there on positive psychology that you might find useful. And then just a reminder that if you have been bitten by the palliative care bug and you want to learn more, there's a series of wonderful resources. There's lots of places you can learn more. There's the Oxford textbook series of, in this case, palliative social work, but there's palliative nursing, palliative medicine. There's wonderful resources out in the community. There now are master's programs in palliative care. For example, I'm part of the faculty at the University of Maryland in Baltimore, where they have a palliative care master's program where you could really do a deep dive in these palliative care principles and look at how you could apply them to your practice. There's the hospice and Palliative Care Nursing Association, HIPNA. There's the American Academy of Hospice and Palliative Medicine, AHPM. There's the Social Work Hospice and Palliative Network, SWIPN. Again, whatever your professional background, there are organizations where you could learn, that you could join and learn more, so that you can feel that, again, you've increased your toolkit, and have additional skills to help you to communicate more clearly, to help people to create shared goals of care, to conduct family conferences in ways that, again, enhance well-being, to help people to feel that their suffering has been addressed, so that folks have less regret. Arguably, offering anticipatory guidance and the minimization of regret are two really important caveats for us in our work. We want to be able to be thoughtful about those and the importance of those kinds of things with the patients that we see. Next slide, please. This gives us an opportunity for about a few minutes now before the close of the time that we have together, for you to ask any questions. In the chat box, please write those down. Sarah's going to read me any that might have come in. If you've got comments, or if you want to share some next steps or a story that you might have of an experience, be happy to hear from that. You also see my email that's on this slide, and even after this seminar ends, or for those of you who might be listening remotely later, please feel free to reach out if I can be of any assistance. And Sarah, do we have any questions that have come in?
We've got one here that we can start with. This person is coming from an outpatient clinic, and the question is, basically, we don't have access to the full team at their clinic, and what can they do?
Right, wonderful. Thank you so much. We know that that's a common concern, a common question that comes up. The reason I talk about palliative care, but then break them down in terms of the concept of the palliative care principles, is that we can think about palliative care in a capitalized way, palliative care, as a consultant service. And that what palliative care is a group of specialist people who have got advanced education and really special competencies that they've, maybe they're board certified as a palliative care provider in their discipline. These are people that come in and they provide a consult to us for the folks who are particularly in need. And that's certainly one way to think about palliative care, as that specialized service, this extra layer of support, this, again, specialized service perspective. But I'm looking at the palliative care principles as like the small p and small c of that. And those are principles we in our own setting can learn and can apply in a generalist way. So I can be a regular, maybe I'm an infusion nurse, and the work that I do is with, again, people in survivorship, that are maybe getting chemotherapy, but are expected to have long and healthy lives. And I might do that work in a setting that doesn't have access to that palliative care consult team. But I nevertheless can learn generalist skills that can help me to be a more compassionate listener, a more clear communicator, a person who's able to look at contextualized care, and can support that patient in exploring the things that matter most to them, and making sure that I share that information with the rest of the team members that I do work with. Hopefully none of us are without at least someone else that we have access to, whether it's a doctor or other nurses, other team members of some sort, that we can put that information and share that in a way that can enhance that person's care. So even if you're not fortunate enough to work in an area that has access to a myriad of specialized providers, hopefully you can develop the general principles of palliative care that can still be applied to the work that you do, regardless of your setting.
Thank you. That brings me to a question that I actually have, in that the idea of palliative care, do you have to get buy-in from every person in the care environment? Specifically, like the oncologist. The oncologist is there to cure the cancer, not necessarily to think about the life after cancer, the ramifications of the side effects and whatnot. Do they have to sort of buy into the idea of palliative care,
Great
or do you work
question.
around that?
Right. So it depending upon where you work in terms of again the politics of such, you may work in a circumstance where you it would be standard medical practice for the consult team request to be as a courtesy from one physician to another. So typically, if we follow the kind of standard medical model for the specialized consult service of whether it's cardiology or in this case again palliative care, typically the answer then would be yes, you would need that oncologist specifically to request the palliative care team as a consult through that formal, again, kind of medical collegial standard of practice. It would be seen again as the kind of correct way to provide that consult. But again, as you've heard me say, these principles are just principles that are associated with improved care and improved practice. So there's again a strong evidence base that would support the integration of these skills, regardless of whether or not there's again that full consult. But to your point, hopefully one of the things that we can achieve by that the study that I mentioned to you that's funded by PCORI, our goal is that if we can increase consumer demand, we're going to go a long way toward helping those oncologists that might otherwise be reticent in seeing the advantages of having a palliative care approach. If patients are coming in and asking about that, if the patients say, wow, this seems like it'd be a really, I'm hearing I've got a couple of choices, maybe a family meeting is a good idea. They might not be asking specifically for palliative care, but because we've integrated those principles into their awareness of, oh, that's something I can ask for, that sounds like that'd be really helpful when I'm making a decision. That's part of changing the way care is delivered. Remember my Virginia Satir reminder that changing anything changes everything. So if the doctor is suddenly being asked to do more family conferences and family meetings than he's ever done before, and he realizes that those work better when he has the social worker or the nurse or the chaplain join him for those meetings, and he suddenly, this way of thinking about this more collaboratively and more contextually, he sees the advantages of it, the patients do better. We're hoping that that's going to change practice, and that there'll be less and less places that don't have access to these kinds of, uh, of specialized players in the future. Again, if consumers demand it, we're likely to see it happen. The parallel that we use often is thinking about the birthing movement in the 1950s. Babies were, quote, delivered by the doctor who had the expertise, and the woman was literally unconscious. And unfortunately, anesthetizing the woman anesthetized the babies, and we didn't have very good outcomes. And so there was a reaction from that, and women demanded to be a part. The Lamaze movement, the birthing movement really was not from obstetrics and gynecologists saying we need to do different. It was from women saying, no, I don't want to be anesthetized through the delivery of a baby. And partners and the male part of the storyline saying, I don't want to be in the waiting room, waiting to be told what my baby is. I want to be an active participant as well. And so now, again, we have almost every community hospital, even the smallest and the most rural places, have birthing units and suites, and babies are delivered, in the loving arms of grandparents and siblings, and this is a collaborative team approach to how to have babies. And some babies are born at home with doulas and folks who come out to them, and some are born in hospitals, and people have choice and they can prioritize their care. We think again that palliative care can create kind of a similar movement, similar awareness, and a similar demand that can result in oncologists in the future, of course, embracing these concepts. That's our hope.
Okay, as you were explaining that, another question came in and it says, in my experience where I live, oncologists don't mention palliative care as an option. Why have physicians been resistant to embracing palliative care?
What a good question, right? One of the things that is if we're, honest with ourselves, folks don't know what they don't know. So if I went to school in, a few decades ago and got my medical degree and kind of have an area of specialization, again, oncology in this case, you kind of only focus on the things that you know to focus on. And you might, this other field of palliative care, you might not really be that familiar with the literature there. That's one of the reasons I started this presentation with those series of Institute of Medicine reports. That's trying to chip away at that, to say this isn't just an area of specialization that is optional. This is something that all of us need to know about, because all of us are affected from healthcare and whether we provide it well or not so well. So the goal is that that folks won't be able to say, gee, I just didn't know. Then once they know, then your question is still valid. Well, why am I resistant? Once I know that it's associated, that the evidence says it's better, then why am I not embracing it? But we also know that people are people, and change is hard. And we tend not to change unless we can be motivated to change. So are there incentives for them to change, or are there stimulus in a negative way that forces the change? And those are two strategies that are being done in healthcare with the change in how reimbursements are done. The idea of value-based care is looking at, instead of fee-for-service care, is looking at reimbursing differently, so that if people recognize that that quality is what's going to be reimbursed, and that quality is associated with increased satisfaction, and people are more satisfied when they have palliative care, that's a way to make someone suddenly care about that differently than they might have otherwise. The hope is, again, that when people begin to take nibbles around this and begin to look into it a little bit, that the evidence, again, will be so overwhelming that their own experiences with patients who have uh, care that better meets their needs, that improves their quality of life, improves their functioning, makes them happier, that will encourage them to do more of it. So we are hopeful that folks will be less reticent when they know more about it and see the evidence of how it works.
Okay, well, thank you so much, Shirley. We are at 12:32 at this point, so we're a little bit over time, actually. So we're going to wrap this up. So let me advance to the next slide at some point here.
And thank you for
There
being
we
my
go.
advancer through all of these.
I know, and I apologize to all our viewers for that sort of glitchy way to see a webinar, but it worked. We advanced anyway. For your continued relationship with Triage Cancer, I want to direct you to, if you have any questions, email us at info@triagecancer.org. Connect with us on social media. We're active there. We'd love for you to follow us and read our blog. It really is full of information that can be helpful to you. And I just want to reiterate the continuing education units, because this is new for us this year. In order to receive your units, you must have registered online for today's session. You will not be eligible for units if you were on somebody else's computer or on your phone, and you had to have watched the entire webinar. Within 1 week of this webinar, you have to fill out the evaluation and the post-test, which will be emailed to you within the hour. And you have, on your evaluation, it asks for your name and email address, and please do not leave that blank. We need those to make sure that you are actually the person who took the test and you actually attended. And again, this is only for nurses, and I will let you know in the future if and when, I should say when, we have approval to offer social work CEUs. All right. Thank you very much for joining us today, and this concludes today's webinar. Goodbye.
Thank you all.